The following podcast is part of a certified educational activity titled Optimizing Precision Medicine in Gastric Cancer Care, Latest and Emerging Evidence on Novel HER2 and Other Molecular-Directed Therapies in Gastric Cancer Management, featuring Joseph Tabernero, MD, PhD. Access the entire activity and complete the post-test at peerview.com/QBE860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, and welcome to the Chair's Take on the latest and emerging evidence on novel HER2 and other molecular-directed therapies in gastric cancer management. I am Dr. Josep Tabernero, a medical oncologist from the Vall d'Hebron University Hospital in Barcelona, Spain. During this presentation, I will be providing a brief overview of the recent developments on targeted therapies in gastric cancer, including the latest evidence presented at the 2020 ESMO annual meeting, just recently held, and helping to interpret what this data mean to our patients. Gastric adenocarcinoma continues to be a very important health problem. Actually, it constitutes the third leading cause of death when we speak globally. Over more than 1 million new cases are diagnosed worldwide on a yearly basis, and unfortunately, more than 75% of these patients are going to die from the disease. We also know that there is a wide geographical variation, and most of the new cases, more than 50%, actually occur in the developing countries. And as you can see in this cartoon, there is a higher incidence in the male compared to the female population. In particular, in the United States, almost 28,000 new cases are diagnosed on a yearly basis. And we also know that the disease, especially when it's in stage 4 or metastatic disease, has a very poor prognosis. We have seen several advances in the knowledge of gastric cancer, in particular in the biology of the disease. The initial seminal data from the TCGA consortium actually evaluate almost 300 gastric cancers, especially in locoregional disease. And thanks to the evaluation of the molecular features of these samples from patients, different subgroups of gastric cancer were established. The most frequent one, the so-called chromosome unstable, accounts for up to 50% of the patients with gastric cancer. And there are particular characteristics of these patients, especially these tumors tend to have an intestinal histology. Usually they have TP53 mutations. And importantly, especially for this educational session, these are the patients that have more overexpression of receptor tyrosine kinases and also ERK activation. The second more frequent subtype is the so-called gastric stable, and these patients tend to have a more diffuse histology. Usually they have CDH1 and RHO-A mutations, and also they have particular features on cell adhesion. This subgroup, the gastric stable subgroup, accounts for 20% of the patients, and this is quite similar to the so-called microsatellite unstable subgroup, especially in patients with locoregional disease, also accounting for 20-22% of the sample. These patients with microsatellite unstable tumors tend to have more mutations. Actually, they have a high tumor mutational burden. Usually they have MLH1 silencing and have activation of several mitotic pathways. And finally, the less frequent subgroup, the so-called Epstein-Barr virus originated, it accounts for around 9% of the patients with gastric cancer. Usually patients with these tumors tend to have high frequency of PIK3CA mutations, also high expression of PD-L1 and PD-L2, CDKN2A silencing, and an immune phenotype in the microenvironment. One of the most important things that had changed a little bit the paradigm of treating patients with gastric cancer is the multidisciplinary approach. And this is something that is clearly recommended in most of the guidelines, if not all. In particular, the ESMO guidelines clearly establish that it's a key factor, multidisciplinary treatment planning before any treatment or even before any therapeutic decision. And of course, we have to involve all the specialists that take care of patients with gastric cancer, including but not limited to the pathologists, to the gastroenterologists, to the medical oncologists, the surgeons, the radiation therapies, and also some other specialists that are important in the multimodal management of these patients, like, for example, nutritionists, supportive care specialists, and also the nurses, among others. All the guidelines now show important treatment algorithms for the decisions of treating patients with advanced gastric cancer. The first thing that all of them evaluate is a full diagnosis of the patient, not only with the conventional workups, but also with a pathological report, a clear evaluation on the HER2 status, and we will refer to this later on. Of course, based on the HER2 status and important clinical characteristics, like, for example, the performance status, we make the decisions in treating patients in the first-line setting. Those patients with a good performance status are usually treated with a combination of a platinum and a fluoropyrimidine. And if the tumor has overexpression of HER2, trastuzumab is added to this combination chemotherapy schedule. When patients progress to the first-line treatment, and if they continue to have an adequate performance status, they are evaluated for second-line treatment that usually consists in a ramucirumab-based regimen, either as a single agent or in combination with paclitaxel. And if ramucirumab is not available, sometimes these patients are treated either with irinotecan or paclitaxel or included in a clinical trial. In patients that have an MSI high status, and depending on the regulatory situation for pembrolizumab, some of these patients are treated with pembrolizumab in this setting. Finally, if the patients progress and they continue to have an adequate performance status, they may be treated with a combination of trifluridine tipiracil, if this drug is available, or in a clinical trial. Also, for those patients that have expression of PD-L1, and if pembrolizumab is approved, these patients may receive pembrolizumab, and also in some countries, they may receive nivolumab. But we'll see right now that for those patients that have tumors with HER2 overexpression, actually there is promising and very encouraging data with new antibody drug conjugates directed to HER2. Unfortunately, for those patients that have a poor performance status, most of the patients are actually only treated with best supportive care. As mentioned before, one of the key characteristics for the precision medicine in patients with advanced gastric cancer has been the determination of HER2 expression. And the expression of HER2, globally speaking, in patients with gastric or gastroesophageal junction cancer is between 15% and 25%. We do know that those patients with intestinal histology have a higher expression of HER2 compared to those that have diffuse histology. And the same for the primary tumor location. Those patients that have tumors originated in the gastroesophageal junction have a higher expression of HER2, accounting between 25 and 35%, compared to those that have tumors that originate in the gastric body, with only between 10 and 20% of the patients overexpressing HER2. There are also clear recommendations on how to perform HER2 testing. First, we usually do immunohistochemistry, an immunohistochemistry test. And then for those patients that have a 3+ overexpression, actually the test is considered positive and without any equivocal characteristic, and no further tests are needed. However, for those patients that have a 2+ expression by immunohistochemistry, it's recommended to follow this test by an in situ hybridization test that will determine whether there is amplification or not of the HER2 gene. And for those patients that have HER2 positive, either by immunohistochemistry 3+ or 2+ with ISH positive tumors, treatment with trastuzumab is recommended in the first-line setting. The initial pivotal study that evaluated the first targeted therapy in gastric cancer was the TOGA trial. This was a phase 3 randomized, multicenter, international study for patients with advanced gastric or gastroesophageal junction adenocarcinoma that express HER2. And for many regulatory authorities, the high expression of HER2 considered, as mentioned before, IHC 3+ or IHC 2+ with FISH positive tumors at that time. We used to do more FISH than ISH. The study, of course, met the primary endpoint, showing an increase in overall survival for patients with this HER2 subgroup when trastuzumab was added to conventional chemotherapy, with a hazard ratio of 4.65, an increase in the median overall survival from 11.8 months to 16 months. And actually, when this data was presented, was considered to be very impressive. After the initial data of trastuzumab, other HER2 targeted therapies have been evaluated in patients with advanced gastric cancer, both in the first-line setting and in the second-line setting. One of the most remarkable studies was the JACOB study that evaluated the role of adding pertuzumab to a combination of cisplatin, capecitabine, and trastuzumab. And although there was a benefit in overall survival, unfortunately, this trial did not meet the primary endpoint. And actually, later on, I'm gonna present you an update of the prolonged follow-up of patients included in this study that was presented at the recent ESMO Congress. Also, Lapatinib, another HER2-directed drug, a tyrosine kinase inhibitor, was evaluated both in the first-line setting, in the LOGIC study, and in the second-line setting with the TITAN study. And unfortunately, the two studies were negative for the primary endpoint. Finally, TDN1, another antibody drug conjugate, was evaluated in the second-line setting in the GATSB study, comparing TDN1 as a single agent with paclitaxel, that was considered one of the therapeutic treatment options in the second-line setting. And unfortunately, this trial did not show, did not meet the primary endpoint with an increase in overall survival. As mentioned before, on this year, we presented the end of study analysis of the JACOB study. And again, this end of study analysis confirmed the evidence of treatment activity with a 15% reduction in the risk of death when adding pertuzumab to trastuzumab and conventional chemotherapy in previously untreated patients expressing HER2. But the study did not meet the primary endpoint according to the statistical hypothesis. And as you can see, there was also a superior time to progression and a superior, higher overall response rate in those patients that received pertuzumab. But again, the study was considered negative because it did not meet the primary endpoint. Fortunately, we have right now novel HER2-directed strategies. And the first class of compounds are what we call antibody-drug conjugates. The most probably relevant one with the encouraging data that has been presented in the last months is trastuzumab deruxtecan. And we are going to be presenting some key clinical trials about this drug. There are other antibody-drug conjugates, like, for example, RC48, that it's ongoing clinical development, still in phase 2, and we are waiting for more updated results of this trial. There are also other more potent monoclonal antibodies like margetuximab, and we'll discuss them later on, and also bispecific antibodies antibodies that target two different areas of the HER2 receptor, like, for example, zanidatamab. Finally, some of these HER2-directed therapies are being combined with different immune checkpoint inhibitors like durvalumab, nivolumab, and pembrolizumab, as we will see later on. The first compound, and the one that has presented more standard data, is trastuzumab deruxtecan. And importantly, this is an antibody-drug conjugate that has important characteristics compared to other ADCs that have been evaluated before. The first one is that it has a payload with a different mechanism of action. This is exatecan derivative with topo-1 inhibitory capacity. The second important thing is that the payload has a short systemic half-life, and it has a bystander effect. And we'll briefly expand a little bit on this important effect. The linker payload is very stable, and it has a tumor-selective cleavable linker, what actually promotes its specificity action into the tumor. And finally, it has a high drug-to-antibody ratio. So all these characteristics for the design of trastuzumab deruxtecan had the goal to improve the efficacy of this ADC in patients with advanced gastric cancer and other HER2-driven tumors. As mentioned before, the classical mechanism of action of an antibody-drug conjugate related to the way that these drugs, these compounds, interacted with the malignant cell. First, the antibody-drug conjugate binds to the HER2 receptor. Second, there is a process of internalization by endocytosis. Third, the drug payload is released after the linker cleavage by the lysosomal enzymes. And finally, there is the cytotoxic effect induced by the drug payload. But in here, we also have another important effect, and this is the bystander killing effect. And for this, actually, the drug the drug payload is either released from the antibody after antigen binding, but before internalization, or it is released after internalization. And by this release, actually, the drug can also kill other cells that are close to the targeted cell for which the antibody is directed. The initial data in patients with advanced gastric cancer came from the phase 2 DESTINITY Gastric 01 trial. And this is a trial that had different parts. The first part was a randomized phase 2 study in patients with HER2 overexpressing tumor that had progressed on trastuzumab-containing regimens. And in here, there was a 2-to-1 randomization to the experimental arm with trastuzumab deruxtecan administered every 3 weeks, or an active comparator that was decided by the physician with either irinotecan or paclitaxel. There were also a second part with 2 different cohorts that were considered exploratory, but very important. Actually, these cohorts evaluated the role of trastuzumab deruxtecan in patients that are considered low HER2 expressors, with 2 different cohorts, one for those patients that had HER2 plus by immunohistochemistry, but ISH negative, and the other for the HER2 plus positive one cross. And these 2 cohorts were evaluated independently, and the data was also presented in this ESMO 2020 Congress. The primary endpoint of the different cohorts of the study was the overall response rate by independent review. So the data from the randomized part of the study was initially presented and recently updated in the publication in the New England Journal of Medicine, led by Dr. Shitara. Basically, those patients treated with trastuzumab deruxtecan had a higher confirmed overall response rate compared to those that were treated with the standard of care. The response rate in the population of patients treated with trastuzumab deruxtecan was 43% compared to 12.5% in those patients that were treated in the control arm. You can see also in the waterfall plots that more patients receiving trastuzumab deruxtecan had tumor shrinkage compared to those patients that received the physician choice of chemotherapy. Importantly, those patients that received trastuzumab deruxtecan had a superior survival compared to those patients that were treated with the standard of care, with a hazard ratio of 4.59, an increase in the median overall survival from 8.4 months to 12.5 months. There was also an advantage in progression-free survival for those patients receiving trastuzumab deruxtecan with a hazard ratio of 1.47. And as you can see, the curves diverge from the early beginning. The safety profile of trastuzumab deruxtecan was generally manageable and consistent with the data that was initially provided in the phase 1 studies. The most frequent adverse events were either hematological or gastrointestinal. Of note, there were some patients that presented drug-related interstitial lung disease, accounting for a total of 10% of the patients, but only 3% of them presented grade 3 or grade 4 interstitial lung disease-related toxicities. If we now focus on the second part of the study, those with exploratory cohorts in patients that have tumors with low expression of HER2, in here, these patients actually had not previously received trastuzumab, but they had also progressed on and after 2 or more prior regimens. And we can see on the right part of this table the data for the low expression cohorts. Again, this data was recently presented at the ESMO 2020 Congress, and you can see both the cohort 1, those patients with IHC 2+, and cohort 2, those patients with IHC 1+. An important proportion of the patients actually benefit from the treatment with a response rate, a confirmed overall response rate of 26% in the cohort 1 IHC 2+, and 9.5% in the cohort 2 IHC 1+. Interestingly, those patients presented also an extended overall survival compared to historical controls. And for overall survival, we didn't see major differences between the two cohorts, although that the numbers have to be taken in consideration because are quite low. But again, the important message here is that for the first time, we see efficacy for a HER2-directed therapy in those patients with advanced gastric cancer that are considered HER2 low expressors. Another ongoing phase 2 study, the Destiny Gastric 02, is recruiting right now, and actually with the same characteristics of the patients that have HER2 advanced gastric cancer that have received and progressed under therapeutic option that include trastuzumab are being treated with trastuzumab deruxtecan at the same dose and schedule in order to confirm the results of the Gastric 01 study. There are other compounds directed to HER2 that are being evaluated as we speak. One of them, margetuximab, has enhanced antibody-dependent cell-mediated cytotoxicity compared with trastuzumab. And the reason for that is because this compound has an Fc optimized portion of the antibody with more affinity for the Fc gamma receptors of the immune effective cells. And as you can see from the initial studies in gastroesophageal cancers, actually there was activity in some patients with a confirmed partial response of 10%. And the ongoing phase 2/3 Mahogany study is evaluating margetuximab, this compound, in combination with standard chemotherapy and also other immune checkpoint inhibitors. Zanidatamab is another class of new HER2-directed compounds. This is a HER2 targeted by a specific antibody. And the important thing here is that this compound has a biparatopic binding with 2 different targets of the HER2 receptor, 2 different epitopes. One is the same for trastuzumab, so ACD4, but the other one is ACD2, that is the epitope and the domain for pertuzumab. So the unique mechanism of action of this compound is based on the hypothesis that by binding of this antibody to the HER2 receptors, actually there will be an extended chain formation and dense HER2 receptor clustering, and this will lead at the end to an enhanced HER2 internalization and then regulation, and eventually an increase in the cytotoxicity. And the initial data presented for gastroesophageal tumors actually show that these patients benefit from the treatment. And this is not only for the population of patients with gastroesophageal tumors presented here in purple, but also for other tumors HER2-driven with other tumor localizations. And as mentioned at the beginning, the hypothesis of combining immune checkpoint inhibitors with HER2-directed therapies is based on important basic and preclinical data. We know that trastuzumab induces antibody-dependent cellular phagocytosis, and this will allow an uptake of tumor antigens by antigen-presenting cells, like, for example, dendritic cells. Also, we know that some cytotoxic agents, like, for example, oxaliplatin, can induce immunogenic cell death of tumor cells that activate different survival and apoptosis pathways. Several preclinical models have actually shown the synergistic effect of combining an anti-HER2 therapy with an immune checkpoint inhibitor. So the hypothesis here is that the combination of an immune checkpoint directed to PD-1 or PD-L1 with an anti-HER2 therapy will result in enhanced T-cell activation and also enhanced ADCC, and therefore this will potentiate anti-tumor immune response in patients with HER2 disease. The first clinical data was published this year by the group of Yelena Janjigian from Memorial Sloan Kettering in the Lancet Oncology, and the results were really very encouraging. These authors treated 37 patients with a combination of a platin and oxaliplatin and fluoropyrimidine. Most of the patients actually received capecitabine and oxaliplatin. And the results that they presented were really very impressive, with a response rate for this population of 83%, a median progression-free survival of 13 months, and a median overall survival of 27.3 months. Obviously, this is a selected population in a phase 2 study, but the results are really very encouraging. And right now, there is an ongoing phase 3 study evaluating the combination of pembrolizumab plus trastuzumab plus oxaliplatin and capecitabine in a randomized setting. And this is the Keynote 811 study. And this slide summarizes different trials that are evaluating combinations of immune checkpoint inhibitors with standard of care regimens in the first line setting. So my key takeaway for this part of the talk is that we have to be prepared for an evolving scenario, and also a new and updated algorithm on the way that we treat patients for HER2 positive gastric cancer. In the first line setting, trastuzumab with standard chemotherapy, a platin, a fluoropyrimidine-based chemotherapy continues to be the standard of care, although we have emerging and promising data from the Mahogany studies and also for pembrolizumab with the Keynote studies, and the ongoing phase 3 studies are going to elucidate a clear role of these drugs in the first line setting. For the second line and beyond, for the all-comers population, ramucirumab combined with paclitaxel continues to be one of the standards of care in this setting. But there is a clear emerging role for the antibody drug conjugates, as we have seen. So the promising data of trastuzumab deruxtecan coming from the results of the Destiny Gastric 01 study are really very encouraging. And also, it's also encouraging to see the activity that we have seen with this compound, trastuzumab deruxtecan, in the population of patients that are considered to be HER2 low expressors. So that's those that are IHC1 plus or those that are IHC2 plus IHC negative. Importantly, and just finishing my presentation, During these days, we have been able to see in the ESMO 2020 Congress, has been in a virtual setting, a very impressive presidential session only focused on trials in patients with esophageal cancer, gastroesophageal junction cancer, or gastric cancer, of the role of nivolumab or pembrolizumab in the first-line setting or even in the adjuvant setting. I'm going to focus on the next slides on the data that we have, especially in patients with advanced gastric or gastroesophageal junction cancer. The phase data comes from the phase 3 Attraction 4 study conducted in Japan, Korea, and Taiwan. So patients with the Asiatic population. In the first-line setting, patients were treated with conventional chemotherapy with or without nivolumab. And you can see that those patients that were treated with nivolumab actually had an expanded progression-free survival with a hazard ratio of 4.68, meaning this an increase in the median progression-free survival from 8.3 months, those patients treated with placebo and chemotherapy, to 10.5 months for those patients treated with nivolumab and chemotherapy. Surprisingly, this study did not show an advantage in overall survival. However, the phase 3 Checkmate 649, this is an international multi-center study evaluating the role of first-line nivolumab combined with chemotherapy, show impressive results in all the primary endpoints, but especially one of the primary endpoints was overall survival. And as you can see here, those patients that received nivolumab in combination with chemotherapy had an extended survival with a hazard ratio of 4.71, the median survival increasing from 11.1 months to 14.4 months. And this was for one of the primary endpoints populations. So those patients that had tumors PD-L1 positives and CPS 5 or more. But also, interestingly, there was an advantage in overall survival for other subgroups. For example, all patients that were PD-L1 positive, again, hazard ratio of 0.77, and for all randomized patients with a hazard ratio of 0.8. The other efficacy parameters that were evaluated in this clinical trial also show a benefit for the addition of nivolumab to conventional chemotherapy. Finally, I want to present the data on the phase 3 Keynote 590 study, and this study evaluated the role of the combination of pembrolizumab to standard chemotherapy in patients with esophageal carcinoma. And of course, there were different target populations in this particular study. Patients were evaluated for the population that had squamous cell carcinoma, CPS 10 or more, but also those patients, all comers that have squamous cell carcinoma, those patients that had, independently of histology, PD-L1 expression of CPS 10 or more, and then all comers. And as you can see here, for overall survival, there was a superior overall survival and a superior progression-free survival for all the different subgroup populations. If we look at the all-comers population, patients receiving pembrolizumab plus chemotherapy had an advantage in overall survival with a hazard ratio of 4.73, meaning this an increase in the median overall survival from 9.8 months for those patients that received chemotherapy alone to 12.4 months for those patients that received pembrolizumab combined with chemotherapy. So my final key takeaways messages are related to the evolution that we have seen in this field of precision medicine with different targeted therapies that will evolve the standards of treatment in patients with advanced gastric cancer. Importantly, what we have seen is that a new compound like trastuzumab deruxtecan, an antibody-drug conjugate, is significantly active in all the efficacy parameters, response rate, progression-free survival, and overall survival in patients with HER2-positive gastric cancer after prior trastuzumab-based therapy. But also, we have seen activity of this compound, trastuzumab deruxtecan, in those patients that had what we call HER2 low expressors, those that have IHC 2+, IH negative, or IHC 1+ gastric cancer. Also, for the first time, we have seen that immune checkpoint inhibitors combined with chemotherapy show a superior outcome, especially overall survival, in this first-line setting in patients with gastric cancer or gastroesophageal junction cancer. So again, I think that we have to be all really very happy and very encouraged because the precision medicine field is moving forward, and this is going to impact, of course, the therapeutic management of patients with gastric cancer, and more importantly, we are going to be seeing a more extended survival for this patient population. Finally, I would like to thank you for being here.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/QBE860. This activity is supported by an educational grant from Daiichi Sankyo Incorporated. This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education.